Hello, everyone, and welcome to the CMSS Leadership Summit on Equity and Anti-Racism. I want to take a moment to recognize that we're meeting just days after the final verdict in the Derek Chauvin trial. The murder conviction and the death of George Floyd does not fundamentally change the need to counter the systemic causes of racism in our nation. We all need to collectively work harder to achieve racial justice. Next slide. CMSS and its 45 member specialty societies have committed to collective learning and action on diversity, equity, inclusion, and anti-racism. This summit builds on a previous CMSS special session in the fall with Dr. Rhea Boyd, who presented a developmental model for our society's work on anti-racism. She explained three opportunities. First, beginning at a symbolic approach, really based on our values, which really reflected the statements that all of our societies put out on anti-racism, to a more descriptive approach focused on numbers and a real focus on diversity and equity. And then finally, how we could ultimately achieve a more substantive approach to anti-racism and systemic change. I hope that tonight's session takes us closer to the substantive action that is needed to address equity and justice in medicine. Next slide. Just want to take a moment to thank Prometheus Research and IQVIA Company, who works closely with us on our clinical registries and research, who is our premier sponsor. I also just want to take a moment to express my gratitude to Bonnie Mason and Bill McDade at ACGME for their collaboration in this important work. Next slide, please. All right, let's get started. I am delighted to introduce our first speaker, Dr. Monica Lypson, who I've had the privilege of knowing since she was an intern just a few years ago. I have to say, when I first met her, I always knew she would be a dean, and though we will definitely miss her at GW, where I have the pleasure of seeing patients and precepting medical residents, she will soon be the Vice Dean of Education at Columbia Medical School in New York. So Monica is not anyone who is ever shy or unassuming in sharing her perspectives. And I know she will give us a really dynamic presentation on the time is now for medical leadership to act anti-racism in medicine. To you, Monica. Thanks.
Thank you, Helen. It's quite an honor to be part of this afternoon, and I'm delighted to hopefully provide you with some thought-provoking fodder to continue to have further discussions about. So let me just, disclosures. I have no financial conflicts with this. I am in the midst of the Society of General Internal Medicine's annual meeting, and I'll soon be president-elect. I'm members of several organizations that you're going to hear from today. In addition, I really find my true north in medical education. I'm a true believer in competency-based education. It starts from my household, which was a big believer in that in K through 12 education. I'm a longtime VA doc, and that has shaped a lot of my views about the healthcare and healthcare system. People know me as pretty honest, but I will provide, this is my perspective, and for now it's my mic. And I'm the associate editor of academic medicine, and I'll tell you a little story about that, because I think as many societies have a publication arm, it's something to sort of think about. I have biases. I'm from the south side of Chicago. I grew up, just to give you an idea, where redlining was conversation at the dinner table. As my family was buying in and out of Chatham, if you remember Raised in the Sun. And this is not a new topic for me. This is concepts of structural racism that I grew up with. I'm a mother, I'm a wife. I identify as African American. I'm a healthcare professional, and I come from Chicago, which is also the land of the three fires. So 3 indigenous tribes really had their origination in the city. What I hope to talk to you about is give you some tools to develop a toolbox to promote anti-racism in the House of Medicine, which all of your organizations represent. Review a conceptual construct for you using symbolic violence to conceptualize racism in medicine. And then hopefully talk a little bit about you using your power of leadership to really address these structural issues. So to tell you a little bit about myself, again, to let you know the lens at which I'm coming at this work, I can get back to the 1870 census on both sides of my family. Unfortunately, I can't go beyond that, right? That's the first census that the emancipated people were recorded in. I haven't found it for my father's family because I refused to pay and waiting for the museum to open back to get that last relative. The other thing that you should know is I'm a product of a pipeline program. You're going to hear from Bill McDade, who's known me since I was 12. I won't tell you how long ago that was. And I've known Bonnie Mason since I was 19. Where we really have gone through this journey of medicine. And there are times where two of these folks supported me, and I hope that I did the same when we were questioning what we do. You'll hear a little bit from Rachel Vagelos as well, who I've also known since I was 22, and we sat on the leadership board for SNMA as medical students. Again, my first project in my fellowship program as a Robert Wood Johnson Clinical Scholars was really in response to what I saw in the medical education system. When I was at Case, in the first 2 years of the medical school curriculum, I had 2 Black faculty members who lectured to me, Janice Wright and Arnie Duncan. And that prompted me to really say, how diverse is medical school faculty? And this is my first secondary data analysis published in Academic Medicine in 2002, really showing the decline at the time of why people were exiting academic medicine. Unfortunately, the numbers might have increased slightly, but the data looks unfortunately kind of the same. And then as I sort of thought about leadership and was growing as a leader, doing my project as part of ELAM, I published a paper as my seminal project looking at what we needed to do to change the educational environment as the clinical environment was changing. And part of that infographic that we published is really the stark reality. Doesn't matter what we think as health professions, our patient population is changing, and we need to react to provide the best clinical care for those patients that we take care of. And really calling that out as a chance to change the educational paradigm as well as the clinical paradigm. So, short circuit, I told you I am the associate editor of Academic Medicine, but that's really a phenomenon that is probably 3 or 4 years in the making. I joined the editorial team for Academic Medicine probably about 4 years ago. In 2020, at the start of the pandemic, this is what the editorial board looked like for Academic Medicine. And we were really struggling about how the journal was going to react to both the pandemic and then the murder of George Floyd refocused what we needed to do around structural racism. And Laura offered us the mic as the editor-in-chief. And if you remember, most of you all publish a journal. There's some magic in the editorial. The editorial expresses an opinion without being opinionated. It allows us to transform without being evangelical. It should engulf without drowning. And it should enlighten us without sort of getting dogmatic, prejudicial, and egotistical. So we took that opportunity and we pulled out the editorial board members who had been historically underrepresented in medical leadership. We said we needed to write this editorial about what academic medicine needed to do in regards to anti-racism. So we have this editorial I'm going to talk a lot of the lessons that are in this editorial. Again, I am grateful to Laura Roberts, who's the chair of psychiatry at Stanford and also the editor-in-chief at Academic Medicine, for allowing us that opportunity. And then I said, well, I have to practice what I preached, and the spot opened up for associate editor, and I applied, and myself and Teresa Chan entered the editorial board. And I have to say, there's a different conversation at times with Teresa and I being part of the board about sort of how we see papers, what should be published, what we should be thinking about. So to get back to what was sort of in that paper, and I'll break that down a little bit and then give you a path forward for your societies, is there's 4 aspects of racism that we should all be grateful to Camara Jones, who actually started this personal campaign at the turn of the century. And she talked about personal racism, institutional racism, interpersonal racism, and structural racism. The personal and interpersonal racism is not what we are here to deal with. It happens. It's what happens often in the exam room. It might happen in the boardroom. It might happen as we pass each other on the day. But we really can only deal with those things if we change the institutional and structural issues. So I'm going to focus a little bit on those 2. When we think about institutional racism, we talk about discriminatory practices, inaction in face of need. And when we talk about structure, we talk about systems and policies that are in place, societal norms that really perpetuate inequalities. And our societies, our committees, and our councils kind of work in the intersection of these 2 issues, right? As the Society of General Internal Medicine, I really sort of am part of the charge to improve healthcare for all, to improve funding for primary care research, to really think about career development for academic journalists. And so how might I define academic medicine? And I would say this is not any different than medicine, but just to give you a perspective, academic medicine is a societal structure that promotes excellence. I have always been proud of being part of that. However, it has historically ensured the entrenchment of systemic racism. That's something that we all have to come to terms of. And I'll give you an example. Let's talk about the Talented 10. I am likely a member of the Talented 10. I have a pedigree, unfortunately, that doesn't look any different than many of you in the audience. I just have a different flavor or color on that. That really is not what we need to do to break down structural issues. We need to bring in many more people and expand that 10th to more the 90th, the talented 90th. Where is the genius across all? We play this part when we think about rankings and elitisms. And we have organizations, many here, that have historically excluded people of color. Give you an example, when I go to an NMA meeting, it's a very different meeting for me personally and what I get out of that than when I go to Society of General Internal Medicine or ACP, right? Those organizations have come through a history and really provide different things to their memberships. So what we did in this editorial is really try to use violence as a construct. And here's a simple Merriam-Webster definition of violence. It's really an extremely powerful or forceful and capable of causing extreme damage. Unfortunately, in the last week, despite the verdict, we've seen multiple instances of persistent violence against Black men in particular regarding police profiling and brutality. And the question we have to say is who gets the benefit of the doubt when confronted with law enforcement? Even our hospital systems aren't often off the hook. And when we had an incident of individual violence, Jacob Blake in Kenosha, Wisconsin this summer, he was paralyzed, unable to move, and he was handcuffed to the bed. And I have to ask the question about the healthcare providers in that system about what was that rationale there? Was he under the arrest, and how did we help and become co-opted into the system of discrimination as healthcare providers? I spent 17 years in Michigan and was there for the continued crisis that's happening in Flint. Nothing is actually much better in Flint than it was in 2014. And if you think about water, it's one of those structural issues that if you can't have access to clean water, it really precludes you from achieving your basic needs. It's Earth Day, so I want to focus a little bit on environmental justice as one of the aspects of social determinants of health, and one of the aspects of what you might see if you wanted to call out structural violence. And I'm using this example from the district here. So this is a map of the District of Columbia and the wards and the census tract within the city. Basically, the greener this map is, the more African Americans in those census tracts and wards. If you notice, where are all the DC trash transfer stations in the District of Columbia? They're not sitting in Northwest DC, where you have predominantly white populations. They're sitting in places where there are Black and brown communities. I provide that map because it's Earth Day. I wanted to talk about something related to the environment. And this is the map of COVID vaccination rates in the district. And you can see the complete opposite, right? So the majority white populations, upper income populations in the district, most of those adult residents have been vaccinated. And if you look at the burden of disease, where COVID really had its largest impact in Black and brown communities in the district, you see a lower level of vaccination. So structural issues persist across any of the social determinants that you want to talk about. So again, in this essay, we talked about using symbolic violence. This is out of Pierre Bourdieu's work. He was a French sociologist who'd gone to Algiers in the middle of the conflict for independence and civil war. And he talked about symbolic violence as violence wielded with the tactic of complicity between victims and agents. And so far, both remain unconscious of submitting to or wielding to it. So it's a complicit conversation that often happens in the dark. And here, fast food burgers fuel the obesity risk in African American women. Who's the blame? Where's the problem? What we know actually is zoning laws might actually have more to do with this than being African American. Where are you allowed to put a fast food restaurant? Where do you be able to have a drive-through? There's a whole, where is it safe? How much does it cost, right? There's a lot of structural issues that probably have more to do with place than race, which again is not a biological construct. So in this paper, we talked about symbolic violence as an exercise of power that confers legitimacy and truth on certain ways of being, seeing, and acting in the world. And we talk about difference in health outcomes, and we use those terms as if we attribute it to biology. And I think we all know that there is no biology of race. This is really a social phenomenon that has an impact on the natural differences in disease. COVID made that very clear, but we talk about it in medicine as if it is a real thing. And our complicity in not wanting to change that is really devaluing Black and brown lives by not doing that. So we really have to be fastidious. Your editorial boards need to think about when papers come out and are our studies are stratified by race. What are they really saying here? So I don't want to leave you on this note. It is the reality that we live in. But what we want to do is energize folks for change. And I think over the next couple of hours, you'll be offered the tools to be able to do that. Because how do we take kind of the mess and really kind of think about more of a structural approach that we can use in our societies, committees, and councils to go forward? So there's an individual level. And I don't want to give this short shift because we all must do the work. We must practice empathy. We must work towards justice daily. You're going to hear two excellent workshops from Dr. Mason and Dr. Nakai about allyship. I'm going to push you to really think about co-conspirator activities. You can share the mic, you can be participating in advocacy, you can be a sponsor, a coach. You can become a student of history, not the history we all got in 7th and 8th grade civics. You can be a student of the history of all peoples of America, in particular, if we're talking about our country. Identify your own biases and privileges. I tried to show that to you by talking about pedigree, elitism, my own background. I still don't allow race in the HPI. I have never done that since I was a resident because I know it will bias my clinical diagnosis. And more importantly, as individuals, we can demand our current organizations insist on the review and change of inequitable and reinforcing policies and structures that we have in place. So I'm going to walk you through some of those things that you can do. Sunny is going to walk you through this with Bonnie about allyship, so I'm not going to spend time in there. They're going to talk about acceptance, belonging, and community. And I'm going to push you to try to use your allyship to dismantle structural inequalities. You'll hear much more about that. And when I talk about dismantling structural inequalities, I'm really talking about how you can become a co-conspirator. And conspiracy is a legal definition. It's written into the law. It's created when two people intentionally form an agreement that is intended to achieve some act through preparation, right? So you usually see this in RICO laws or things you write, it's a co-conspirator in the action, but conspiracy is just a word. We should co-opt that. And we want to talk about becoming deliberative in our actions around activism. And becoming one means choosing to take on the consequences of participating in acts that are supporting marginalized and minoritized people. And if you remember the story of how the Confederate flag came down at the state capitol of South Carolina, I was a Black woman and climbed up to the top of the flag, got it down. The story that you didn't hear about, her co-conspirator, was a white man who stood at the bottom, who knew that he was going to be arrested by the police. He knew that there wouldn't be violence against him and protected her to allow her to go all the way up the flagpole. He didn't steal her glory. He didn't take away from that, but they co-conspired in that act of civil disobedience. That's how you're going to change the system. So I'm going to call us to say, let's get less allies and move to more co-conspirators. And I am a student of Paul and Maram Batalden and the quality world, and say you can only do co-production if you are co-conspirator in changing the system. So let's talk about the structure of our own societies. So if you have an issue with affinity groups in your organizations, I hate to say, all of us in that slide that Dr. Burston showed us at the beginning of this presentation, we're all part of affinity groups. All of our societies, groups, councils are affinity groups. We gather with people with common identities, right? I just told you about a gathering of academic journal internists. We create safe spaces. So at our meeting, we're talking about burnout of the hospitalist. We're talking about support of primary care. We're talking about structural racism, right? But we've created a safe place where us journal internists can feel open to talk about this issue among each other. We protect our own interests. And unfortunately, sometimes we protect our own interest under the guise of what's good for patients, but it actually might not be. It might be really for our own interests. We keep our members up to date. We challenge misconceptions. We advocate for ourselves. We promote innovation, safety, and quality. And I want you to think about that when you think about affinity groups within your own organizations. And if you have an issue with those, think about those principles I just said. That's the definition of an affinity group. We are all members. If you're sitting on this call, we are all members of affinity groups. And so I want to talk about one layer that doesn't get a lot of excitement in our organizations, but it also might help us think about how our very own structures can be dismantled and thought about differently to really as a tool in the anti-racism toolbox. So middle management is one place that I want to talk about. And when I say middle management, I mean not just middle management of our executive societies, but also the associate members. So the members in our societies in that 5 to 15 year range. And I want to talk about community engagement of our work. Here are the CMSS principles of education, quality, and professional identity. And most of our societies, groups, and councils function along these 3 lines. And I think we are pretty proud in medicine, in the House of Medicine, to say we actually do pretty good. We've moved from hierarchy to holarchy. You might have an org chart in your organization that talks about education, advocacy, and publications. That you're very proud of, and you might do that in a hierarchical way. I think most of us, either function in a matrix organization where we talk about that, but that's how we have formulated, and we've been really good about that within our societies. I want to prompt you to think also in a different way, that maybe our organizational charts are more like a tree. And maybe the senior vice presidents and the vice presidents of your organizations, or those members in the 5 to 15 range, are really the roots of the organization. They're the people who make it go. You have the CEO, and then you have all of these support people in the middle. And when you think about equity, though, you can think about it 1 or 2 ways. We can do window dressing. This is an example of window dressing. Just quickly, these are all men on this tree. You have a woman CEO, but has that really changed the conversation, either within the organization itself or among the membership? You could really strive for gender equity. You could say, okay, we're going to look at our membership and we're going to try to figure out who are those senior vice presidents, who are the roots, our VPs, and we're going to do that, and we're going to lose the lens of full diversity of those who have been historically underrepresented. Or our tree can really focus on our diversity that is really representative, both in the operational structure of our organizations, but also in our membership of our organization. So that's just might be one way that I think we've all focused on leadership and the diversity at the leadership level. But I'd like to challenge you to think about leadership at the middle management level, at the staff level within your societies. How are people feeling included in an inclusive environment in those meetings? So that's just one tool, structural tool, just looking at your organizational charts that could help you think in an anti-racism way. The way you might approach that is an asset-based framework where your best and brightest focus on the care of the most vulnerable. You think about the community-based participation activities that you have in your local environment. We all have made lots of statements recently, which are necessary but not sufficient. We must advocate through the written world word, but also act. We must support the immediate surrounding environments that all of our societies exist in. Most of us have buildings, organizations, etc. Think about supporting your employees at all levels. I think that's one of the things. I'm going to show you an example of a conversation I had with a staff member at SGIM just today. And then where we could excel as societies is think about rankings, index, and metrics. We are the voice of expertise. How can we prioritize a different structure? Instead of US News and World Report, instead of the Blue Ridge Report, should we be thinking about a new index for health equity? Should we be thinking about an index to help institutions, hospitals, and healthcare centers think about institutional diversity or inclusion indexes? Do you feel part of the team? In your organizations, as they're situated, are they exploring the lived environment that they're around? This is a bus. The first thing I did as a primary care resident at the Brigham was Judy Ann Bigby put us on a bus and took us into the community so that we really understood where our patients were coming from. I did that again when I was at the University of Michigan. They had the Rhodes Scholars Tour. It was the first time I entered a Supermax prison, and it was the first time I entered a Ford manufacturing plant. It was one thing to talk and see the world from the Ivy Tower in Ann Arbor. It was another world to see what Michigan was like for the patients that we took care of. The Rodman Center here at the George Washington, where there is a center embedded in the school that really focuses on community outreach and social justice principles, looking out for what are we going to do in the community and bring the community. What does the community need to enhance their vaccination rates? They told us, and then we adapted. So what I'm saying here is that we all need to create teams, and teams learn with, from, and about each other. That doesn't mean it's fun all the time. Scott Page's work, the diversity bonus, will tell you that teams, diverse teams, are a little bumpy. But we do get the bonus at the end of a better outcome that looks at excellence, if we bring all of our team members to the table and they can bring their full selves to work. So think about that as you're building your diverse teams, communities, etc. in your places. Here is a classic diversity strategy that people will put forward. We're going to think about talent in our organization. We're going to come up with new metrics, rewards. What's the structure, the process, how we're going to do that in the organization. And we're going to do that through culture, capabilities, management, and diversity councils. And, you know, the classic statement, if you don't deal with the culture, it's going to eat strategy for lunch. So think about that within your organizations. It's the culture of inclusivity. It might look diverse, but do people feel like they can bring their full selves to the meeting? Do they feel like they can bring their full selves to the work? So if we think about, again, the increasing diversity of the population, in terms of our health professions associations and that workforce, where's the diversity thinking about CEOs, differing abilities, senior vice presidents, VPs, directors? And then think about the communities you're embedded in. Most associations happen to be living in Chicago, the district, Arlington, Virginia, Texas. You know, there's lots of organizations between Fort Worth and Houston. But how are we dealing with the populations that we actually have buildings in, from which the people who staff our offices sit? How are we thinking about that? And so here's an example. I am the future president of the Society of General Internal Medicine. There's a long history of diverse presidents in that organization. We pride ourselves in terms of the work we've done in the Health Equity Commission and Minorities in Medicine Interest Group as part of that. But it was the staff this summer who said we need to have a different conversation within the society about how we work. We need to have a different feel so that everybody feels like they can come to the table, and we needed to address that. Here's the example. So I should have been using this background today to show off our annual meeting and the SGIM leadership. But another staff member who also identifies as Black, and I had a little conversation this morning about who chose this background, because if I use this background, nobody's going to see me. Now, I don't feel any less included from the society, but it also tells me who was in the room when making a decision about the background that people were going to use for the meeting. This is a small example of how we have to think differently about what we do and how people may or may not feel included. So again, the House of Medicine, we need to remember, acknowledge, and apologize. The AMA is kind of the poster child for apologizing to the National Medical Association for the quite frank racist discrimination against membership. We need to use the science, the implementation science approach of review, change, review, plan, sustain activities. Remember, there's no quality without equity. We need to collect data, help our members do that, provide benchmarks, actual metrics, and then really be actionable towards historical injustices. And my new cause is the award committee. This is a place where you can leave this meeting today and have an immediate effect on your organizations. Look at the award committee. So what does medical leadership do? We want to recruit and we want to retain our memberships. We want to grow our social capital. But this is all work of inclusion. How do you set up networking events at your meetings? How do you expand members and staff social capital? Who is invited to talk? Who decides about meeting content, the speakers? What research is promoted? Standing committees, how does that process even work? Is it who is a mentor or a mentee? Is it an election and only certain aspects vote? Oh, how is that process done in your society? These are all things that can help you diversify within the structure of what you have absolute control over. And all I'm saying is what you want to do is reject groupthink. You don't want to do things just because you've always done it that way. That's how we got into this structural problem. We want to actually think outside the box. And again, awards review is one of those classic places about who gets nominated. Why are only those people nominated? How do we actually diversify the nomination pool? How do we think about the people who do the selection? Those awards are really capstones in people's career. And so we want to think about how we promote that. And then when you think about retaining, again, this is the work of inclusion. This is the hard work. So how do you think about your standing committee structure? How do you do turnover with wisdom? We know this in the gender, in trying to diversify gender, right? We know that if we leave certain people in place for a long time, that's one of the reasons that we can't diversify leadership. So we don't want to lose the wisdom, but we probably want to have some turnover. How do you do launch committees? That's on the academic side, but how do you think about your new members? How do they get reinvigorated, re-involved? How do your employees think about their world? How do you do sponsorship? How do you demonstrate sustained commitment? I think a lot of us are waiting to see how these statements play out in our organizations. Are they just talk? Or is there really a commitment there? And really, how are you going to reconceptualize the environmental culture? So you want to think about dismantling structures that actually say, I live my world in the hidden curriculum. So there's often a hidden message that say that you don't belong. So the pictures of the founders of our organizations, who was there in the room, that is a message to people that they don't belong. What's the legacy of the organization? As a mother of a 14-year-old and a 9-year-old, a length of a meeting beyond 60 hours gives me a minute of pause. It might actually change my decision to participate. And then what is the definition of success? Again, looking back at that award, what would prompt people to have awards? And then I'm going to sum up and have a little time for questions and dialogue. What type of leadership does this take? What do we have to do to be able to really mobilize and do that? I gave you one tool, which is co-conspiracy. But this is some reading that I did this summer that has sort of stuck with me and kept me whole. And this is Robert Franklin. In full disclosure, I married a Morehouse man. So Robert Franklin is the 10th president of Morehouse College in Atlanta. And he wrote this book on moral leadership. And it was particularly telling in this time of COVID. So he talks about if we want to be moral change agents, what do we have to do as leaders? We have to ask grand questions. We have to give a compelling, provide compelling questions and then give a compelling response. We need to address the public at large, not just our tribe. If I want to convince people to support primary care, I just can't talk to a bunch of primary care doctors. Right? I have to actually be able to expand my message bigger than that. They communicate in short form. You might actually articulate, I didn't do such a good job today, but they want to have a clarity of purpose in their communication style, and they want to catalyze us for action. So what are we going to do next? So these are some tools that you can use in your personal leadership box. And what he talked about is then framing the issues. So you want to frame those issues and communicate in ways that invite. I spent 2 years working for the Department of Veteran Affairs and overseeing undergrad and graduate medical education for the VA, and had no problem advocating for diversity and the support of historically Black colleges and universities, as well as Hispanic serving institutions while I was in that role in the past administration, because I just changed my language. I didn't really change my language. I talked about the economic benefit of diversity, right? I'm a student of Scott Page, right? If we have more diverse teams, we can expand the economic pie and we can improve the economy. That rings to a certain population out there. You can have that conversation. You want to try to live an exemplary life. This is not about perfection. This is really about being undaunted by failure, to actually stand up, to try different things within our societies and committees and councils and say, we're going to try something new. It might not work, but it's really with the clarity of purpose that will allow you to try. You want to invest in the next generations to build enduring institutions. I think that's why you're all here today. And then having done your best, you really want to teach others how to move on. This is Diane, and my favorite quote from David Brooks in his book on character is, you know, I've stopped working on my CV, I'm working on my eulogy, right? What are people going to say when I'm no longer there? So I hope what we did today is talk about, you know, as medical leaders and as societies, councils, and committees, we really need to act in a way that ensures that medicine becomes anti-racist. It needs to become anti-racist to improve the care of our patients and to improve the work environment for those that participate. So what we did is review the application of a theoretical construct. I hope I offered you at least a frame to think about this using symbolic violence. And that's what we do in medicine, right? It's not usually a physical violence, but many of our policies and procedures are violent. They're just more symbolic in nature. I hope I gave you a toolbox that you could use talking about co-conspirators. I hope everybody is energized to become an institutional agitator. I think you'll hear from Dr. Yancey and the others today that will help you get on that bandwagon. I want you to consider that middle management diversity and inclusion, right? Like, where's that middle aspect of not only your organizations and the buildings that you support, but also your memberships, thinking about structural change and, more importantly, inclusion, and then use your power of leadership to address structural issues. So thank you. I'm apologizing in advance. I'm going to be bopping in and out of this meeting because, again, I am part of our annual meeting, but it's been a real pleasure and I'm honored by the invitation. So thank you.
Thank you so much, Monica. That was extraordinary as expected. We do actually, I think, have some time for questions. And feel free to put the questions in the chat box if you'd like, or go ahead and just add them. Feel free to use the raised hand function and we'll be happy to call on you. I see we already have one. Oh, that was a thank you. It doesn't count. There's some really good comments, I thought, particularly around mentorship and sponsorship. And I wonder if you want to talk a little bit more around questions and ideas around how we as specialty societies can also help sort of enlarge the pipeline of future health leaders.
So there's classic data, really a lot of the work of the executive leadership in academic medicine, ELAM, that really shows that women and minorities have lots of mentors. They're kind of mentored to death. That's actually not really the issue. The issue is really about sponsorship. So the way I like to think about sponsorship is if you're having a committee meeting and you're thinking about, here's a new opportunity for somebody to be helpful in our society, who in that room gets thrown out as people you should talk to? And think about who is doing the talking and supporting. So a sponsor, so the way I think about sponsorship means I got some skin in the game. So I'm going to tell you about Bonnie Mason, right? I don't know, right? I know her work. I might talk about it to a bunch of primary care doctors. They might be like, who's this orthopedic surgeon you're telling me about, Monica? Right, I've got skin in the game, right? So my reputation's on the line, but I'm sponsoring her for an activity that I think she's good at. So one of the things the societies can do is say, okay, when we get these names, who are they? What do they look like? Are they just the mentors and mentees? Is it just a convenient sample? That would be one way to do that. I think that is one approach, excuse me, to think about that. And then think about formal ways to get, and often in our societies, younger people involved as well.
Yeah, so whole series of questions, lots of agreement with you in addition. So one question, just kind of going from the bottom up here, is questions about any thoughts about to increase the number of diverse members on the boards of our societies. You touched on editorial boards, and I liked your concept as well of thinking about leadership overall, but you know, the boards make decisions. Any specific thoughts about how our organizations could help there?
Yeah, and I've been working with some venture capitalists about that. So I'll use an extreme example because we don't have the same problem they have. And what they'll say is no one has the expertise to sit on a biotech firm. We want to diversify the firm, but nobody's got the expertise. Can you help us? That's kind of how the conversation usually goes. And what we say is, okay, no one has the expertise now. I'm not buying that, but even if I buy that argument, then what are we doing to prepare people to be able to sit on our boards? So one of the things that our societies can think about is not just what the next level, who are we going to tap to kind of become, you know, the new member at large, kind of the classic, but how do we prepare people to become able to be a member at large? I think that's the piece we don't think about. And if you think about kind of leadership training in any Fortune 500 company, they often will start that pipeline very early. They know that not everybody will get there. Not everybody will be members of our boards, but we need to start to actually educate people what that means. Rachel and I, like, and you need to also look at where people had previous experience, right? They might not have experience in your organization, but I know Rachel from the Student National Medical Association, right? There are leadership structures. You don't know what I do in Jack and Jill of America, right? So a kind of historic African-American mother group focused on the well-being of Black children, right? Like there's a skill set that people have that you probably need to tap into and ask different kinds of questions.
Yeah, no, that's great. I think there's a number of questions in the chat that get at this issue of sometimes just the pushback you receive when you try to make an argument that the committees need to be more diverse in terms of whether it represents the demographics of the membership as a whole. Also just questions about, you know, other, how do you get leadership to stop being afraid of an equity platform, for example? And, you know, sometimes you mention equity initiatives and leadership kind of, and volunteers and others clam up. Advice for folks who are at the front, you know, really trying to drive change in both appointments as well as actions around equity in their societies?
You want diversity of all perspectives, right? So I'll give you a simple approach and a more difficult one. Sometimes, right, if I'm creating I have a small work group at work, and I'm creating a team, and we've done kind of that fun strength finders exercise, right? When I create that team, I purposely don't want to put the same people on the team. We don't want everybody who's analytic. We don't want everybody, right? The one thing we're often missing is a cheerleader in medicine, a woohoo kind of person. And so you can use that exercise to think about your own committee. So you want the young membership. So if you want to be vibrant, you want somebody who can bring that perspective. You want a perspective of people who haven't historically participated in your organizations. I think this is not about quotas. This is about historical perspectives that will actually make the outcome better. And I think that's the framing that people really need to understand and focus on. And so again, it's sort of, what are you doing at the developmental stages to get people prepared to go into those committee rules? Another thing that you can try is shadowing, right? So you can have a committee. Most of us have more than enough members, right? There's shadowing opportunities, right? To try somebody out, have them sit on a meeting, see what that's like. Those would be ways that make not only the old guard more comfortable, but also expose folks to different ways of being.
Yeah, there are a couple of questions in the chat from some folks who I think have been trying to work from the outside, when they've left an organization, for example, or even when you're trying to find other co-conspirators. Suggestions for those perhaps who are trying the outside in approach rather than always just the, you know, how we can make change from within.
Some of that is personality. My sister is a lawyer, and like I'm a work within and try to speak truth to power. Some people are much more effective telling the power from the outside they need to change. So some of that is sort of what your comfort level is. The next level is really trying to get a movement going. Dana Matthews, who's the dean of the law school here at George Washington, in her Just Medicine, really talked about the quiet revolution in civil rights, where it was the doctors who got together, who really desegregated healthcare, right? It was a quiet, it's not the revolution, it's not the civil rights that you hear about. It is these doctors and dentists, many of them members of the National Medical Association and National Dental Association, who worked fearlessly to try to change the system. Sometimes that meant lawsuits, sometimes that meant societal pressures. And so that might be a strategy for those who find themselves on the outside. It's funny, I don't get scared when members sort of say, I need to protest, right? Like if you're scared about that, then are you hiding something? If members are upset, and Darlene knows about this, right? Like I have a big segment of our society that really believes in a single payer program. We want them engaged. We want them part of the conversation. We don't want to isolate them, but we also know what's best for the society in terms of messaging and advocacy.
Yeah, that's really helpful. There's no shortage of great questions here. One that's raised that I love your thoughts on was a question around, there's a lot of interest, obviously, in building the diversity within the specialties, but so much of that is dependent on building diversity into medicine in the first place. Thoughts about how we can collectively help build the pipeline of diversity into medicine across societies. Obviously, it's a very similar kind of approach we would all take, but it doesn't make sense for us all to do it in different ways. If there are ways to collectively work most effectively to do that, would love your thoughts there.
I called Bonnie Mason and have her talk about her founding of Nth Dimension. So Bonnie has done that, and I won't steal her thunder about creating programs that diversify specialties in medicine. That being said, the reason I showed you a pipeline is because that's what it is, and a lot of us need to be at our community level. I know when I was on the executive board for the National Board of Medical Examiners, the staff really did a community outreach in Central Philadelphia. Algebra by 7th grade is really the trick. If you really want to think about the educational pipeline, that is if you don't have algebra by 7th grade, health professions is really kind of off the key. And so where can we either advocate to help? Where can our volunteers help? And really kind of support that kind of K through 12 pipeline. That's one. However, maybe the standards to be part of the profession are wrong. I think we need to beg the question about what are the standards to be part of the profession as we think about diversity. I told you I am a competency-based educator. I believe that the most vulnerable needs the best doctors, but I'm not sure that that is represented in a USMLE score.
Yeah, very, very fair point. Couple of questions about training, for example, around things like when you do implicit bias and you find different perceptions in training and patient characteristics between residents and attendings from diverse backgrounds. How do you raise awareness of these kinds of issues and really improve cross-cultural communication? I know you've done some of this at GW, but how does it not just feel like an exercise, but something that really gets built into the fabric and the culture of our work?
So back to the individual work, right? We all need to do some individual work. I'm also, and we all need to be open to our trainees, because our trainees have actually got, quite frankly, the majority of them kind of understand that. The problem is we're not receptive to their feedback about how you could do it better. So I think that's one thing that if you look at the average age of revolutionaries since since the start of time, it's a cohort of people in their teens and early 20s, right? Like listening to them to affect change, I think is really important. So you actually might have answers sitting in your own backyard. You probably think of them as novices instead of thinking of them as experts in this realm. So that's one thing. Doing the work yourself is another thing. And then I used to teach empathy and communication skills. I can't change how you feel. I don't try to change how you feel, but I can change how you act. I can put policies and procedures in place, right, that change your actions and give you feedback and corrective responses. So if patients are complaining about the way that they're perceived, what are those corrective actions back to individuals? If we're looking at quality data that certain communities have lower standards, the answer isn't I need a case mix adjustment. The answer is, what are we doing to fix the quality issue?
Yeah, that's a great point. There's another really interesting question. We hear, and as you know, there's a pretty wide range of political perspectives and geography of different members of societies. One person asked, how do we accelerate this work despite the potential we might get for pushback, and particularly an argument of, how do we counter arguments we might lose members by focusing on equity and anti-racism?
I think I saw Patricia Turner in this chat box. I actually think the American College of Surgeons and their work on gun control is one of the best models. Because talk about a diverse group on a diverse topic with diverse, they as a society were able to come up with a pathway, with an internal pathway to get them to a consensus, and then really use their advocacy and an external pathway. So I would look to them, and I have no expertise at that, but I often use them as an example.
Yeah, no, I was at the session they did on that as well. I thought it was really quite masterful, the way they were able to take a range of perspectives, starting with gun-owning trauma surgeons as a starting point. I thought was really very, very creative. There are also some incredibly interesting, boy, we could do this for days, and I know you need to go to your meeting soon. But there are any thoughts about how you would actually evaluate how organizations are, the metrics of success? There's an ongoing effort, as you've probably heard, between ACGME, AMA, and AAMC that we'll be part of shortly, we hope, on trying to standardize the demographics with an eye towards ultimately standardizing, hopefully, the metrics to be able to understand success. How do we look at the successful adaptation of ideas around DEI and anti-racism for our societies in particular?
So Helen taught me about quality, in full disclosure, and you just start. So I think perfection is the enemy of the good in this case, and the question is trying something. I think that's where we actually have to be as societies, about putting our heads together. Here's a potential inclusion index. It might work, it might not. I think also stop being so myopic in medicine that there's probably other professions that have done the work and we just don't know about it because we think we're the only ones who sort of have this problem. But I actually think that the issue has to be not being afraid to try. And I think that's where we are. I think people are afraid of trying.
I think there's a lot of concerns about saying the wrong thing or feeling like you're not approaching it in a significant enough way, then you get accused of not doing enough. And I think part of it here was we really looked to all of you today to kind of give us very bold ideas for what our societies really could do to make a significant difference. And I think your comments about, for example, moving beyond sponsorship and mentorship and really thinking about being co-conspirators, I think we're really right on point, and lots of good comments around how important it is to look at that. Any sort of thoughts that you would want to share as you think about what might you, if you had to tell these societies 3 things they could do tomorrow? I think you gave us one around awards, right? Start that out. That's a clear one. What else would you suggest that we think about?
again, I would look at your middle management, your SVPs and your SVPs and your VPs at the society, because remember, those are the people who actually, so, right? I see Daryl Lynn occasionally, but the people I actually interact with at ACP are at the other levels. And I guess the question is really focusing on who is there, what lens do they bring, how do they represent themselves, and how do we actually improve? So that would be one thing. And then I think if there are pertinent topics that the society needs to address, and I'll give you diversifying your specialties, right? So here, people often, I'm a primary care doctor, I'm a general internist, that's okay. I want to refer patients to neurosurgeons that are diverse. I want to refer patients to otolaryngologists that are diverse. I want my patients in reproductive endocrinology to see a diverse team when they go. Like, this is really about our patients and what they need.
Yeah, that's perfect. And I think it's a remarkably perfect segue to Dr. Yancey's talk next about equity. So good timing. I just saw him popped up on the screen there. So thank you from all of us, especially from me, knowing that you're doing double duty at the SGIM meeting while coming to our meeting today. And thank you for all of your good teaching of me over the years. It's been very bi-directional, even though we started out as me as you're attending. So thank you, Monica. It's really been wonderful having you today. And we'll share some of the additional questions that came in with you and see if we can get some additional feedback offline. All right. Thank you so much.